presentation by Doris Mwenda. She will be presenting, she will be online, she will be presenting on a study she did for her thesis as a postgraduate, and which is the prevalence and management of obstetric outcomes, neurological complications among women with preeclampsia, with severe features and eclampsia at Kenyatta National Hospital from January 2015 to December 2022. It was a retrospective cross-sectional study, and she did this for her thesis.
Once again, thank you so much for the opportunity. I'm Dr. Doris Mwenda, a gynecologist at Tharaka Nithi County, Magutuni Sub-County Hospital. Thank you for this opportunity to emphasize and remind ourselves on the prevalence, management, and obstetric outcomes of neurological complication among women with preeclampsia with severe features. As Dr. Kigondi has said, this is the study that I did my thesis. My supervisors were Dr. Alex Bosire and Dr. Patrick Lagot Olan. Next. That is my outline, the literature review, study justification, broad objective, methodology, result, conclusion, and recommendation. Next. So to literature review, a study that was conducted by Rifaus et al. In 2021 in Libya, a cross-sectional study. Its objective was to investigate the outcomes of patients with severe preeclampsia. The result was that most of the patients underwent emergency C-section, and 13% of the newborns had low birth weight, that is less than 1.5 kg, and 10% had intrauterine fetal death, and 9% and who were admitted in NICU died post-delivery. The next study conducted by Sain et al. In 2018 in India, we wanted to see the spectrum of neurological complication in eclampsia in a tertiary hospital. We found that the incidence of neurological complications associated with eclampsia was 20.63%, and 40.62% were admitted in ICU. They used magnesium sulfate for the management of seizures, and the neurological complications, they are common in eclampsia. Next. Next. So the study justification was that preeclampsia is a disease that can affect several organs and systems, and neurological repercussions are particularly feared and provoking, and we have imaging techniques that are available within our facilities that are able to elucidate the pathogenesis of these complications. And in addition to mortality, the morbidity associated with preeclampsia is very significant. Next. The morbidities including the blindness, persistent neurological deficiency, secondary to stroke, and later cognitive impairment. So for us, it is very important to understand the magnitude of neurological complications, and that it is very possible to identify, and it is very possible to prevent. And from this study, we will be able to see how we can go about it. Next. So our broad objective was to determine the prevalence, management, and outcomes of neurological complications amongst women diagnosed with preeclampsia with severe features and eclampsia at Kenyatta National Hospital between January 2015 to December 2022. That was our conceptual framework. So the independent variables were patient characteristics, And the signs and symptoms were the headaches. Those are the signs and symptoms that when you find the patient with, we should take action. And the headache, mental confusion, blurring of vision, deficient in visual field, and conversions. And the neurological complications were the cerebral edema, intracerebral hemorrhage, subarachnoid hemorrhage, cortical vein thrombosis, hypertensive encephalopathy, posterior reverse encephalopathy syndrome, and that were the outcomes, the maternal and perinatal outcome. Maternal being blindness, cognitive impairment, coma, post-traumatic stress disorder, and status epilepticus. Perinatal preterm birth, low birth weight, neurological disability, intrauterine fetal death, and stillbirth. Management being supportive and surgery. Next. So the methodology was a retrospective cross-sectional study. The inclusive criteria was women with preeclampsia with severe features and eclampsia from 20 weeks gestation until 6 weeks postpartum, who were diagnosed with neurological complications. And the neurological complication, as we've stated them from the conceptual framework, the exclusive criteria was incomplete files and pregnancy-related conditions like thrombotic, thrombocytopenic, papillohemolytic uremic syndrome, which can cause symptoms like headache, confusion, and seizures, and conditions like fatty liver diseases and hepatic encephalopathy, and also patients with other conditions that can cause neurological symptoms like brain abscess, tumor, encephalitis, meningitis, cerebral malaria, and COVID-19. Next. So the sample size, we adopted census method because when we started the study, we discovered that most of the files we missed the symptoms, and most of them, the diagnosis was made mostly in ICU, but we lacked things like CT scan or MRI to make conclusive diagnosis. Next. So to the result, the first objective, the prevalence. So out of 2,714 patients, those who had preeclampsia with severe features and eclampsia within that duration, 66 developed neurological complication, giving a prevalence of 2.4%. Next. The neurological signs, most of the sign and symptom was seizures, 90.9, followed by mental confusion, then headache, hemiparesis, blurred vision, and visual palsy. Next, please. The imaging that was used, in Kenyatta, we used a brain CT scan and MRI. CT scan was the most used, the frequency of 61, that is 92.4%. And cerebral edema was mostly, it is the most diagnosis that we found. The rest was cerebral infarct, intracerebral hemorrhage, subarachnoid hemorrhage, intraventricular bleed with mass effect, and posterior reversible encephalopathy syndrome. So the management, most was conservative management, and 3% was both surgery and conservative management. Before we go to the next, I know someone will ask me what was the conservative, but move to the next first. Maybe, yeah. Oh, yeah, the conservative management, they used magnesium sulfate. These are the drugs that were used. But when we talk of conservative management, first of all, I think we all know the first thing is to immediately stabilize the patient, that is the airway, breathing and circulation, ensure that the airway is patent, the oxygen is saturating well, and the positioning of the patient, monitoring the vitals, observing the neurological signs with Glasgow Coma Scale, papillary response reflexes, and also the prophylaxis, the magnesium sulfate for prophylaxis, and optimal blood pressure control, ensuring that the systolic is between 150 to 140, and the diastolic is 90 to 105, and also fluid management. When we are managing with the fluid, ensure that we don't, there is risk of pulmonary edema and cerebral edema. So at least 80 mils per hour, and the urine output should be at least more than 30 mils per hour, and evaluating the neurological injury and timely delivery. Okay, I've not stated those ones there, but I think we took from our study, we concentrated on the magnesium sulfate and the drugs. Nifedipine was used for optimizing, it is the drug that was used more for optimizing BPs, and you can see there was mechanical ventilation for the airway. Thank you. Next. So the maternal, that is the maternal outcome. 53% there was no adverse outcome, and 47% there was a presence of adverse outcome. So when we manage these patients with that knowledge, we are able to prevent adverse outcomes. The most was cognitive impairment, followed by coma, death, then blindness, epileptic, and hemiparesis. Thank you. Next. So those are the perinatal outcomes, and the most one being preterm, followed by low birth weight, and then stillbirth, and then neonatal death, intrauterine fetal death, and neurological disability. Next. So to conclusion, the findings showed low prevalence in neurological complication, that is 2.4%, and most of the patients were managed conservatively. Magnesium sulfate, phenytoin, and diazepam were mostly used, and it revealed that 47% had at least one adverse outcome. Among the most cognitive impairment and coma and mortality being the commonly identified outcome. And perinatal outcome, the most one was low birth weight, preterm, stillbirth, neonatal death, and intrauterine fetal death, and neurological disability. So to recommendation, our recommendation was to incorporate neuroimaging in patients with preeclampsia with severe features and eclampsia, those who present with neurological symptoms, to help in early diagnosis. For instance, a patient can come for an elective CS, and maybe the BPs are within normal, and then they come for checkup after 2 weeks. The patient comes with a BP of 150 over 95. She complains of headache. It is going to be keen because most of the people, they will give the patient an analgesic and they'll be like, maybe ni spinal, you'll be fine. And then later, you might find the same patient coming with blood vision and not able to talk. They come to the casualty and CT scan is done to ICU. The next time there is a maternal mortality. So it is very important to ensure that we use our neuroimaging and be very keen on the symptoms. And also it is important to document and report any neurological complications associated with preeclampsia, with severe features, and eclampsia during our MPDSR, and encourage health care providers to report all the cases promptly and conduct further prospective studies in assessment of neurological complication among patients with preeclampsia. I think there is one of my colleagues who is doing his thesis on neuroimaging in patients with preeclampsia with severe features. on what is found and what is supposed to be done. Thank you. Those are my references. Thank you so much.
Thank you very much, Doris. Very